Hello everyone, good morning. I have now got the TOG summary for the remaining TOG articles from the January 2023 TOG. I hope you'll find these useful, and if you do, then don't forget to give this video a thumbs up and also subscribe to my channel if you haven't already. Okay, so our first article is titled as Management of Term Breech Presentation. So 5% of breech presentations are presentations of breech at term. ECV success is 50%. The current UK guidance is offer ECV from 36 weeks to primips and from 37 weeks to multips. Extended or frank breech is seen in 2/3 of breech presentations. The rest, about a third, is either flexed, complete and semi-flexed or incomplete breech presentation. Risk factors for breech presentation include nulliparity, Caucasian ethnicity, congenital uterine malformation, multifibroid uterus, raised maternal body mass index, oligohydramnios, polyhydramnios, and small for gestation age. So the term breech trial was a randomized control trial. It looked at vaginal breech birth versus cesarean section and found that there was significantly increased rates of perinatal and neonatal mortality and serious neonatal morbidity in the vaginal breech deliveries, 5% versus 1.6% for the cesarean sections. And this was with no significant differences in maternal mortality or morbidity. So factors influencing success of external cephalic version, that's ECV. So factors that increase success are high provider experience, multiparity, increased maternal age, non-engagement of the breech, pre-procedural tocolysis, low maternal body weight, posterior placenta, flexed or complete breech, amniotic fluid index of over 10. Factors decreasing success of ECV, nulliparity, maternal obesity, extended or frank breech, and footling breech. Additional risk factors for vaginal breech birth include hyperextension of the fetal neck on ultrasound, estimated fetal weight of more than 3,800 grams, estimated fetal weight of less than 10 centile, footling breech, evidence of antenatal fetal compromise. So upright breech position. So upright breech position is in labor is associated with significantly reduced need for maneuvers, neonatal birth injury, and also shortens the second stage by over 40%. Delay of 90 seconds or more at any stage following birth of the fetal pelvis is likely to require intervention. A delay of over 5 minutes from delivery of the buttocks to the head of over more than 3 minutes from the umbilicus to the head needs intervention. So this is quite a useful table, not just for the exams, but also in your obstetric practice to know exactly when to intervene and at what stage. So do give this table a few minutes to look through so that you can have this picture in your mind, especially when you are dealing with a breech birth on delivery suite. Next TOG article is Pitfalls of Prenatal Diagnosis Associated with Mosaicism. So the National Health Service Fetal Anomaly Screening Programme in England, Scotland and Wales helps to is a screening test to pick up those that are high risk of trisomy 21, 18 or 13 in the first trimester. It's available from 9 weeks up to 21 weeks and 6 days. So this table shows you the sensitivity, specificities, false positive, false negative rate for different trisomies and according to the risk. So for T21, it's a high risk then sensitivity is more than 99.9%, specificity is 99.8%. For trisomy 18, sensitivity is 97.4% and specificity is 99.6%. So these are quite useful numbers, and they are very easy questions for your exams. So do make sure that you do give a few minutes to these slides so you can learn them really well, and it's easy marks if they do end up coming in your exam. So reasons for false positive and negative non-invasive prenatal testing results. So reasons for false positive include confined placental mosaicism, maternal chromosome mosaicism, inadequate fetal fraction, maternal malignancy, vanishing twin. Reasons for false negative tests: mosaicism, early gestation age of sample, inadequate fetal fraction, increased maternal body mass index, so inadequate fetal fraction, prolonged storage of samples. So the third article is Thromboprophylaxis in Gynecology, a review of current evidence. So without thromboprophylaxis, the incidence of deep venous thrombosis in major abdominal surgery goes up from, it's between 17 to 40%. Risk of VTE following surgery exists in the first 12 weeks, with the first 6 weeks is when you'd see patients presenting with this sort of diagnosis. In the NHS, there is a 95% target that needs to be achieved for completion of venous thromboembolism risk assessment for every hospital admission. So for hospital-acquired thrombosis is defined as any venous thromboembolic event occurring in hospital or within 90 days of hospital admission. 50 to 60% of all thromboembolic events are actually hospital-acquired. So you've got, this is an important little diagram that shows you that this is a triad of endothelial injury, which results as a result of inflammation or surgery. There is stasis because of immobility, venous obstruction, pelvic mass, lithotomy, for example, and then hypercoagulable status because of cancer, surgery, pregnancy, sepsis, postpartum period, thrombophilias, and estrogen therapy. So a triad of these is what increases the risk of a thromboembolic event happening. So hyperemesis is a recognized risk factor for venous thromboembolism. You can see because of dehydration resulting in hemoconcentration, and also there is immobility. Ovarian hyperstimulation syndrome is again clearly linked to venous thromboembolism. There's a 100-fold increased risk of VTE in pregnancies that have IVF and are complicated by OHSS, as opposed to just a 5-fold increase with IVF pregnancies that are not complicated with OHSS. Hemoconcentration and vascular endothelial dysfunction leads to a procoagulant state, and hence in patients with severe OHSS. Thromboprophylaxis in severe OHSS is to be continued for the duration of the first trimester. So risk of VT increases from first trimester because of the hypocoagulable state of the pregnancy. Thrombin production increases right from 5 weeks of gestation. So very early on in the pregnancy, you have clotting factors that are going up in order to make this hypercoagulable state possible. So cancer increases risk of VTE as well. Incidence of VTE is 5 in 20 per 10,000 women years in pregnancy, 40 to 65 in 10,000 women years for postpartum. So you can see the difference: 5 to 20 to 40 to 65, 3 to 15 in 10,000 women years for combined hormonal contraceptive users, compared with only 1 to 5 in 10,000 women years outside of pregnancy. Risk of VTE is greatest in the first year of use. So marginally higher risk of having VTE in women using combined hormonal contraception, significantly reduced with drospirenone or third generation progestogens versus second generation progestogens. Norgestimate is an exception because the risk is similar to levonorgestrel. So norgestimate, all this third generation contraception, it's still the risk of VT is still similar to the second generation combined hormonal contraception. Combined hormonal conception with ethinyl estradiol is less than 50 micrograms lower risk of VTE than a higher dosage. Combined contraception should be stopped 4 weeks before elective surgery and restarted at least 2 weeks after surgery. Progesterone-only contraception may be offered as an alternative. So post-op period risk is highest in the first 2 weeks of developing venous thromboembolic event. So risk factors for thrombosis: patient-related, age over 60 years, BMI over 30, medical comorbidities, previous history of VTE, thrombophilias, cancer, pregnancy or postpartum, combined hormonal contraception, smoking, ethnicity, black race, acute admission with inflammatory or intra-abdominal conditions. Procedure-related risk factors: increased length of surgery, significantly reduced mobility, laparotomy, and procedural complexity. So for early pregnancy, risk assessment has to be completed. So personal history of VTE or a total of score of greater than 4, pharmacological thromboprophylaxis if no contraindication is to be started. If there is OHSS, you start it again, and if there is need for hospitalization like hyperemesis in early pregnancy, then you do start them on thromboprophylaxis. Now, if it's an ectopic pregnancy and surgical management, patient undergoes surgical management, then they should start thromboprophylaxis as well. If the patient is as an ectopic pregnancy but undergoes conservative or medical management, but there is personal history of VTE or a total score of more than 4 equal to 4, then they should start thromboprophylaxis as well. If in early pregnancy there is medical or surgical miscarriage, then the patient and there is personal history of VTE or a score of more than or equal to 4, then they should also start thromboprophylaxis. I must say it's very important to know that all the risk factors that account for these scores of 4, for example, and what constitutes these scores like BMI, age, and so forth. Because I remember there was there's a common exam question where they get you to they'll give you a stem where they talk about different risk factors for a patient, like the age, BMI, what sort of delivery they've had, and so forth, and then they'll get you to work out a score, and based on that they want you to say whether this patient should start thromboprophylaxis or not. So it's very easy marks, and it's very useful to know. So please do go through that guideline that talks about the different risk factors. It's under the green top guidelines, so that you know exactly what constitutes a 1 point, a 2 points, and so forth. So for patients requiring gynecological surgery, personal history of thrombosis or underlying malignancy, then they should have thromboprophylaxis. If they haven't got cancer or haven't got any personal history, then assess VTE risk. If they're high risk, then give them thromboprophylaxis. If they're low risk, then no anticoagulation is needed. They should have stopped their HRT, their combined combined hormonal contraception as per guideline. HRT can be continued to be, it's considered a risk as a risk factor for risk assessment. So COVID-19 on its own is a risk factor for VTE. Remember this when you are trying to work out any risk factors for patients. So hysterectomy for benign causes There's a higher incidence of VT with laparotomy than laparoscopy. Vaginal surgery carries very low risk of VTE. Laparotomy has increased thrombotic risk than any other routes of surgery, such as vaginal or laparoscopic. Risk factors for bleeding to be considered before pharmacological thromboprophylaxis, so acute bleeding, acquired bleeding disorders, concurrent use of other anticoagulants, acute stroke, platelet count less than 75, uncontrolled blood pressure, untreated inherited bleeding disorders. Procedure-related risk factors, procedures with a high risk of bleeding, risks related to anesthesia within 12 hours of an anticipated lumbar puncture, epidural spinal anesthetic, and within 4 hours after lumbar puncture, epidural and spinal anesthetic. Thromboprophylaxis based on VTE score. So if the score is 0, low risk, then just recommended thromboprophylaxis would just be ambulation alone. If the score is between 1 and 4, it's moderate risk. Then they require intermittent pneumatic compression and plus or minus graduated compression stockings during hospitalization. Risk is between 5 and 8, high risk. Then they require the compression stockings along with low molecular weight heparin or low molecular weight heparin alone for 7 to 10 days. If the risk is above 9 or equal to 9, highest risk, they require intermittent pneumatic compression along with low molecular weight heparin or low molecular weight heparin alone for 30 days. So this is a VTE risk score for patients undergoing gynecological surgery. Very, very important to know. As you can, please note that some of these things score for, it's 1 point, but it actually gives you 2 points for score. So remember that as well. So for example, things like a BMI of above 40 would give you a score of so at least more than 2 points. So it's important to know this figure, these figures and these points really, really well, so you know exactly how to score this in your exam. Well, many thanks for listening. I hope you'll find this useful and it'll help with your exam revision. Please don't forget to give it a like and subscribe to my channel if you haven't already.